which speaks to the interdisciplinarity of our research. Now, being a health economist, I can't help looking at the figures and the money. I read this morning that mental health problems account for about 23% of the burden of disease in the NHS and about 11% of the funding. I think in terms of research funding, that's probably even less as a proportion of research funding. But the other thing to say about that is that that is changing. There is an increasing focus on mental health in policy, as you'll have heard from our Prime Minister this morning, and in the health service, and in research as well. And certainly a commitment to mental health research here at the University of York. So it's a pleasure to welcome you all here today and to introduce our first speaker, our Pro Vice-Chancellor for Research, Professor Deborah Smith.
Thanks very much indeed, Karen, and welcome everyone. Let's just wait for our colleagues to join us. There's plenty of seats at the top. It is really fantastic to come in here this afternoon and see so many people here from across the university and from across our whole community. Not just our staff, not just our senior professors and our more junior researchers, but our postgraduate and undergraduate students too. You're all really welcome here as we join together on World Mental Health Day. As Karen said, there's a huge economic imperative, there's a life course imperative to get to grips with mental health. And I think if anybody saw last night's 10 o'clock news and saw the way in which our colleagues around the globe are treated when they have mental health problems and the patients in chains in a certain African country, I think we will all have our minds sharpened by how important it is to get to grips with what is a really critical human condition which has been very largely neglected, I think, in the face of physical disease and being able to work with physical disease. And we're fortunate here at York because we have a plethora of excellent colleagues working in different areas of research. And what we want to do this afternoon is to share some of that work with you and to tell you why we think it's important and why we think it's important to engage with the whole university. So this is not just an area of activity for our researchers and our academic staff and our PhD students. It's an activity for everyone, our staff and students across the whole community. So if you pick up on that this afternoon, there's always more information to be found, and we really actively encourage you to engage with the work that we're doing. I'm just going to say on a couple of slides the vision as we go forward before I pass on to people much more expert than I am to talk about the research that they're doing and to engage with you there. So the story so far and our future ambitions. And let me say, to start with, that we have a bold ambition here at York for a USP. I'm sure everybody knows the use of that term, you know, a unique selling point, but perhaps that's a rather crude way of saying it. We want to be known as a university that takes mental health really seriously through our whole community, not only by the way we work with our staff and students, but by the way we use research methods to try to understand and to try to improve what we can do in the future. So the work here is building on the work and ambition of our Student Mental Ill Health Task Group, which after a really pivotal report was written by Emeritus Professor Hilary Graham on the state of mental health and our student body in the university and what we should be doing to make things better. That was produced in 2016, and since then we've had a real drive to provide widespread support across the university through our student body, but also impacting on our staff to support colleagues with mental health issues, to recognise those and to be able to take action to help move things forward. So that was the start point, really, although colleagues here have been doing first-rate mental health research since long before that date. But that's what brought it all to a fore and really allowed us to build an ambition to be world-leading in our mental health research and its impact on our community, both in York, both nationally and internationally. This is an international endeavour as well as a national endeavour. And we set up the Mental Health Research at York Strategy Group, and that group is working to try to bring our ambitions together and move things forward. So there's real strength and breadth in our mental health research here at York. I'll just give you 3 examples there, and you're going to hear from colleagues working with these groups: the Mental Health and Addiction Research Group, the Cochrane Common Mental Disorders Group, the International Centre for Mental Health Social Research, and there are others. Groups of colleagues across our departments, across our disciplines, working together to address key issues in mental health research. And there clearly are a plethora of opportunities to explore in this space. Just a few are named there. The mortality gap for those with severe mental illness. Why do those people die at a younger age? The prevention of anxiety and depression. Children and young people's mental health, largely rather ignored. Workforce well-being, something that's very close to Karen's heart in her role as research champion. So there are many opportunities to do groundbreaking research, to really do work that will make a difference. And I think that is the driver for many of our colleagues. The key issue here then is working in partnership. None of us can do it alone. We need to work in partnership, and that's not just partnerships within research groups and between departments, but it's partnership with our staff and our students. So partnership as a community. So also we have value in key established and emerging institutional partnerships. I'll name just two here, but there are more developing. Our partnership with the Tees, Esk and Weir Valley NHS Foundation Trust, and I know we've got colleagues here from that organisation. Our partnership with the Mental Health Foundation, and you're going to hear a presentation from that group of individuals later today, telling you something about the work they're doing and why it's important. The value of developing new partnerships and knowledge exchange opportunities, sharing what we know with others to make a difference in the world. And we've had some really exciting recent successes in this area, providing new opportunities to work in this space, and I would name there the UKRI funding opportunity, the Closing the Gap Network Plus, which will link the work here at York with other universities and other institutions. And I suspect Professor Gilbody is going to say something about that later on this afternoon. And then, as I've emphasised already, the value of working in partnership with staff and students, developing unique interdisciplinary approaches to mental health research, bringing people together to work together, and importantly too, supporting the career development of the next generation of talented mental health researchers, so that we build the foundations and we grow the foundations for the future. Because the issues of mental health research are not going to go away overnight. We can do a lot, we can build structures, we can make progress, but this is sustained activity that needs to continue into the future. So we really need to be building the next generation, encouraging our students to get engaged, to be involved, and building the next generation of talented researchers in this area. So that's as much as I wanted to say. I'm going to put up as my last slide this figure here, which really illustrates some of the work we're doing, but also gives you the link to the web pages where you can find out more detail about some of our research. But there's no better way to hear the detail than hearing from the experts. So I will say, have a great afternoon, and it's great to see so many of you here. And introduce, I think, Professor Simon Gilbody, Professor Rachel Churchill. I think you're going to do a double act, but I look forward to see what that's going to look like. So thank you.
Good afternoon, everyone. I'm so glad we made the effort because World Mental Health Day has been happening for a number of years, but this is probably the second time we've managed to celebrate it here in York. And we had a full lecture auditorium last year, and we've had to book an even bigger auditorium this time. And I think that reflects the interest, both within the university and in the wider community, in mental health. And the fact that it's been on the news today, I think, is testament to the fact that a conversation has started. And I feel that we are part of that conversation. So I'm Simon Gilbody. I'm a professor of psychological medicine here at the University of York and at the Hull York Medical School. We've got a fantastic medical school here at York. And so I'm proud to sort of work in both those organisations. But I'm the director of the Mental Health and Addictions Research Group. And I'm going to try and set the scene, but not spend too long doing that, because I don't want to distract you from so much more compelling presentations than I'm able to give. But I'm going to talk about mental health research here at the University of York and use a few illustrative examples and talk about some of the things that we've achieved in the short period that we've been at this, and maybe give you a taster for what we're up to, and encourage people to participate, to form partnerships with us in this endeavour that we're so proud of. So just got a couple of slides to orient us in the challenges that we face in mental health. And Karen started to talk about this a bit already, but there's a headline figure there. So depression, the most common mental health problem. There will be people in this room that have lived experience of disorders like depression. You'll know people who suffer with depression. This is the most common mental disorder, and the World Health Organization, that august body, has done surveys across all countries in the world, and they know now that this is the leading cause of global disability, more so than cancer, more so than heart disease, and most people are not aware of that fact. And one of the things that's been really useful in raising the profile of depression is recognising the economic impact of disorders like depression. £17 billion a cost to the UK Exchequer. If we were to think about some of the more severe and enduring mental health problems, disorders like bipolar disorder or schizophrenia, well, that group of people are a disenfranchised group. They experience some of the most profound health inequalities of any section of the population. And I'm going to give you a picture, and I hope that you can take that picture away to make you think about what the nature of this problem is and how that inequality seems to be getting worse over time. So I've got a picture here that's a graph, and I apologise to those people who don't look at graphs day in, day out. But there are two stories here. One's a good news story, a success story for our beloved NHS, and the other is not such a good news story about people with severe and enduring mental health problems. So here's the good news story. This is life expectancy running up the vertical axis, and we've got years running along here on the horizontal axis. So we look at life expectancy back in the 1980s, and for men and for women in the general population, if you follow this line onwards and upwards, you see that life expectancy increases year on year, and that's a testament to our great NHS and to preventive medicine and us treating ill health better. So people live longer, people have healthier lives now. So that's the general population. And here is the same story, mapping life expectancy year on year for people with schizophrenia and bipolar disorder. So life expectancy is reduced when we look in 1980 for men, and you can see this is getting worse and worse over time. So this is what we call a health inequality. It's an inequality that exists between people with severe mental ill health and the rest of the population. And health inequalities are something that we're increasingly bothered about. But this is a health inequality that seems to be getting worse rather than better over time. So a good news and a bad story. And this has been something that's very much focused our mind about how we might research the nature of mental ill health and what York's contribution might be. And I'll talk about some of our work in this area over the next few slides and tell you about what we're going to do over the next few years. But a little bit about what we do here in York that's perhaps a little different from that which happens in other universities. And York's not the biggest university, and there are other universities in the United Kingdom that have been at this a lot longer than we have. But in the short period of time in which we've been working in mental health research, we've grown substantially such that now we punch above our weight in terms of the quality and the outcomes and the impact of our work against other universities in this country. And one of the reasons is that we take a life course approach. We work right across the age span, and you'll hear some very nice examples of research that works at both ends of the age spectrum in the presentations this afternoon. But the other thing I would say is one of the things we're really good at York is science, and it's underpinned by world-class science. But the scientists don't live in silos here in York. The notion of interdisciplinarity is written right through all the things that we do, and I'll give you some examples to illustrate that over the next few slides. But we start where people seek help in the NHS. So primary care is where the majority of people with depression receive care. They never see secondary care mental health services. we bring to bear this population perspective. We think about groups of individuals and how we can ensure that the population mental health is impacted for the good. And we take an epidemiological perspective. We draw upon the very rich social tradition, the tradition of social research and economic research that exists here in the University of York and predates our interest in mental health. And we ensure that academics, clinicians, scientists, people like myself who have worked in the NHS but have also trained as scientists, work together with people who know the world's best methodology to answer the questions that are important. And I say that we punch above our weight. We've generated and we have captured substantial research income to support the work that we do. And we work with NHS partners, and we are the lead research organisation here in the great county of Yorkshire. I'm not a Yorkshireman, but I've sort of become a Yorkshireman over the past 30 years in the time that I've lived here. But our research serves the needs of 6.2 million people, and that's a really great place to do research because the stuff we do benefits our local population, and I'll give you some examples of how we've done that over the next few slides. But the final point I want to make on this slide is the notion that all the work that you will hear about this afternoon is co-produced, because at the centre of good interdisciplinary health services research, applied health research, is the involvement and the collaboration and the co-production with people who have lived experience of mental ill health and carers of people who have lived experience of mental ill health and people who use mental health services. So this is really important to what we do here at York. So I talk about this notion of interdisciplinarity. The work that is done in the area of mental health doesn't exist in a single department, so that immediately means that we can't work in silos. So the group that I lead, the Mental Health and Addictions Research Group, is just there in purple, but I work with colleagues from the World-Class Centre for Health Economics. You're going to hear a little bit about the work of the Cochrane Common Mental Disorders Group from my colleague Professor Rachel Churchill in a minute. We've got an International Centre for Mental Health Social Research. You'll hear about some research from that organisation. And we are increasingly working with colleagues in digital creativity. So we've got emerging collaborations in that area. Our work is the trials that we do are some of the best in the world, and we do that not by accident but because we work with the York Trials Unit. You'll hear about some of our work in child and adolescent and young people's populations from my colleague Barry Wright, who's going to talk to you in just a few minutes. We have a computer system that we built here in York that underpins and supports and tracks the care of 3 million people in the NHS. And I can see my colleague Byron somewhere in the audience, who's the architect of the primary care management information system that supports the care of people. And I can't waste another opportunity to talk about our brilliant medical school. We produce some of the best doctors in this country, and our doctors graduate with a very deep appreciation of the psychological dimension of health and illness. And I'm proud that we contribute to the education of our doctors. So, those are our university partnerships, but Professor Smith has also mentioned a really strong partnership that underpins our work with our local trust. So Professor Joe Riley is in the audience, and who leads our collaboration with one of the largest NHS providers of mental health services, the Tees, Escombe Weard Valleys NHS Foundation Trust, TUV. But I'm also delighted that you're going to hear this afternoon from our colleagues from the Mental Health Foundation. This is a new partnership that I wouldn't have been able to speak about if you'd have come to last year's talk. And that's a really important thing for us to help us form a platform to grow and do better things. So it's great that the Mental Health Foundation are here. So, Professor Smith's whetted your appetite about one of the things that we're really excited about going forward. So, the funding councils that support research in this country, the Medical Research Council, the Economic and Social Research Council, there are several there. Traditionally, they've worked in silos. They've funded research in their own areas of domain, and they recognise that good research that tackles the problems related to mental ill health requires that notion of interdisciplinarity. So they've pooled their resources to support the building of networks to do the best research in mental health in the world. And They had lots and lots of competition to form those networks, and I'm delighted to let people know in this audience that we were one of 8 successful networks that have been formed, and it won't escape your attention. Myself, as a professional northerner who sees it as his job to ensure that there's the equitable allocation of research funds in this part of the world, that we're the only one that's outside of the southeast. There's one in Glasgow, but that makes me feel that we contribute on a national level with mental health research, and this is a really exciting area of work for us. And the areas that we're going to tackle is we're going to tackle improving physical and mental health, working at the bucking the trend in that graph that I showed you a few slides ago. And we're going to think of creative responses to how we might address that mortality gap. We're going to work in green space to see how natural environments can be harnessed to improve people's physical and their mental well-being. We're going to see how we can utilise big data, the data that are collected in everyone's lives, to see how we can use that as a force for good to improve people's mental health. And that notion of mental health and informatics is one that cuts across lots and lots of departments here at the University of York and beyond. So we're looking to form partnerships with other universities in the north of England and in other parts of the United Kingdom. York is a global university, and we aspire to do more on the global stage, and so we're particularly proud to speak of international global development and collaborations that have emerged from this university. So we have a programme of work that's going to take place over the next 5 years, where we're going to do the sorts of things that we've done in this country and work in partnership with 4 countries in South Asia, so Bangladesh, Sri Lanka, India and Pakistan. This is going to be internationally excellent research supported by grants of £2 million by the National Institute for Health Research in the United Kingdom. And we're one of only 2 centres in the United Kingdom that's been awarded an international development grant in this area. So we're going to work together with our partners in South Asian countries to improve mental and physical health together. And we had our first International Congress just a few months ago here, and that's one thing that we're very excited about. So I'll leave you with the notion that we've got global presence and increasing global reach, and there's nothing that illustrates more the international reach of our work than that work of my colleague Professor Rachel Churchill, who heads the International Common Mental Disorders Group within the Cochrane collaboration. So I'll stop talking now and I'll pass you over to Rachel. So thank you for your attention and enjoy the rest of the afternoon.
Thank you very much. Thanks, Simon. That's a really nice beginning to the day. And just while Sheila's getting things set up, I think it's worth saying that we had a real struggle when we were trying to pick things for this talk, because there's so much going on internally in York and also in terms of our partnerships outside. And we were absolutely spoilt for choice in terms of the topics that we could cover and some of the more innovative approaches that we might be able to use. So as Simon says, I'm Rachel Churchill. I'm a professor of mental health evidence synthesis, and also I lead the Cochrane Common Mental Disorders Group and provide some leadership for the academic mental health strategy group that Debbie referred to earlier. The reason we wanted to really flag the Common Mental Disorders Group for Cochrane was we thought this was a really nice way of demonstrating opportunities for people to actually get involved in mental health research, both internal to the university and externally. So for those of you who aren't aware, Cochrane is a not-for-profit organisation which is absolutely dedicated to making up-to-date evidence available for decision makers across the world. And in our group alone, we're one of 52 different groups in Cochrane that covers different areas of healthcare. Our group is concerned with common mental disorders, so depression, anxiety, eating disorders. And we produce what's known as systematic reviews. I'll quickly turn to that in a minute. To help decision makers think about what's important when they're trying to make healthcare decisions. And those decision makers could be anybody. They could be policy makers, they could be patients, families, healthcare providers, and so on. The way we produce those reviews is through working with, in our group at least, more than 1,200 authors across 34 different countries. So we really are truly a global network. And we have a number of satellite groups that really speak to key areas in our field. So We've already heard a little bit today about the suicide and self-harm figures. If you've heard the news, you'll know that we probably lose about 6,000 people a year to suicide and self-harm in this country alone, and it's the biggest cause of death for men under 45 years old. So it's a key priority area for our group, and we have a satellite group that has specialist expertise in that area that we work directly with to produce this evidence. Similarly, global mental health, Simon's mentioned a little bit about this. We're specifically interested in the mental health of people in low and middle income countries, whether they have physical health problems or otherwise. And I think a really startling figure, just to raise the profile of that, is that in low and middle income countries, about 0.5% of their national budget is spent on mental health on average. So this is not something that gets a lot of coverage, but it really is something that needs its profile raising. And that's one of the things we try to do through our reviews. And then, of course, today's main theme around World Mental Health Day, children and young people's mental health. We have a satellite that's based in New Zealand, in Auckland, that has specific expertise around the mental health of children and adolescents. And again, another startling figure that my colleague Barry Wright, I hope, will be speaking to later on, is that before the age of 18, most, I think 75% of mental health problems that arise in adulthood have already started. So we really need to think about the mental health of children and young people and the transition into adulthood if we're actually going to do anything at all to address some of those problems. So I think one of the reasons that we were trying to demonstrate this was people talk a lot about academic research and you know, the different types of studies and the hierarchy of studies and so on. What we just do in systematic reviews is ignore all that and make it very easy for people to understand research evidence, whatever the type of study they come from. And I've tried to put, some of you will have seen the evidence pyramid before. I've tried to explain what we do in the context of the evidence pyramid. So you see different types of studies in there: trials, cohort studies, case control studies, case series reports and so forth. And some of them can be high quality and low quality, which is reflected in this particular zigzaggy line here. And what we try to do with systematic reviews, rather than being the top of the evidence hierarchy, we use systematic reviews as the prism through which we understand what that evidence is telling us from primary research. So we can understand whether it's high or low quality and help decision makers use that evidence in deciding what they want to do with their money. So this is just a little taster of the sorts of reviews that we do. We have reviews for a variety of different areas and different interventions. And we try and make those things very accessible to people, whoever they are, so you don't have to read through turgid academic documents. You can read little précis that we make widely available through our knowledge mobilization activities on our websites. But we've also been experimenting recently with some alternative approaches to how we present evidence in a simplified manner so that people can understand and get their hands on it very quickly. So you can see here we've got, and this is really thanks to my colleague, my tremendous colleague in the audience there, Dr. Jess Hendon, who's really worked hard to try and put some of this together. We've tried to really simplify what systematic reviews do in terms of the questions that they ask. So in this case, we were interested in e-health interventions for children and young people with chronic and life-limiting physical conditions. And we wanted to see whether or not it was true from the academic evidence that actually e-health interventions, so digital mental health interventions, actually helped these people manage their conditions in terms of the depression and anxiety they suffer. So we explain here why the review is important in fairly straightforward terms, and we have tried to explain what the evidence actually tells us. And in this case, and so frequently this is true, it's not very much, because we haven't got the right kind of evidence to answer the questions that are important. So in this instance, our conclusion from this enormous piece of work, which unfortunately draws together many, many trials which have probably cost a huge amount of money and been done across the world, we really don't know what the answer to this question is. And that's really striking because that's frequently the answer we get from systematic reviews. When you bother to look at high quality evidence, you find out that actually you don't know what you thought you did. And therefore, we're quite limited in terms of the availability of the knowledge that we have for good quality decision making. So just a quick nod to the things that Simon's already talked about. Our healthcare evidence is used by health practitioners, patients, families, policymakers and the public. But in order to ask the right questions, we have to engage with all of these groups so that we know what it is that's important to people. And I've just put down there a couple of examples of the types of organisations we work with. We have a formal partnership with Mental Health Foundation, which you'll hear about later on, and we're working with Mind and other groups. You've already heard about Tees and Weir Valley's NHS Trust, and we also have a similar partnership with Northumberland, Tyne and Wear. We work routinely with NICE and WHO to inform their guideline development, so the decisions that policymakers make should be underpinned by work that we have done. And in addition to that, we've been trying much harder to work with people who really matter in this conversation and who tend to get excluded from the conversation in terms of how academic research is delivered. And that's people with lived experience and their families and carers. And we've done a number of formal pieces of work to identify what are the important questions to those individuals so that we can inform the work that we do within our group. And we've done some exercises like this in depression and in bipolar disorder. We've recently done one in digital mental health. And we're in the process of completing one in partnership with the McPinn Foundation on children and young people's mental health. And that should be published fairly shortly. Oh, I seem to have turned the presentation off, sorry. Fairly shortly at the beginning of November. And the idea really was to work with people across the UK to identify what their questions were through a survey. And you'll see we had a huge number of questions submitted from a large number of respondents through this survey approach. So more than 2,500 responses and 5,000 questions came into that exercise that were deliberately elicited from people who don't normally get into the conversation about where we should put research money. And the idea is that we come up with a list of questions that will then inform the people who pay for research, so research funders and academics and their partners, in order to drive the research agenda forward, taking account of those important individuals. So we look forward to seeing some of the findings of that. I just wanted to flag up the profile that these sorts of priority setting approaches is given. So this is the one we produced in digital technology just recently. Just a really quick flag that we have a stand outside, and we're very, very keen to work with people inside the university and outside the university. And I would really encourage you to go and talk to Jess Hendon about the opportunities that might be available to do that, because I think systematic reviewing and the nature of our products is one area where everybody can get involved. So please do have a look at our stand outside. There was one thing I specifically wanted to flag about Cochrane. Cochrane and our partners in Oxford who support our work actually produced a website called Students for Best Evidence, and it's one of the ways that actually students can get involved in not necessarily undertaking a piece of work, but commenting on a piece of research that's been produced. Not necessarily always positively, I have to say. So sometimes we get people who are undergraduate, postgraduate students at all levels, who offered to write blogs for us on the evidence that we've produced. And these are published. This is actually one that's just come out today that's published from our group, Psychological Therapies for People in Humanitarian Crises. This Psychological Therapies for Treatment-Resistant Depression in Adults was done quite recently, both by medical students who offered out of interest to produce a piece of work on our behalf. So I really do encourage you to look at the resources that we have available and potentially the ways that you could get involved in doing Cochrane work. And I've listed some of the ways at arm's length that you could just see what we do, ways that you might be able to participate at a low level, and also ways in which you can learn skill sets that would enable you to engage potentially in this kind of research at whatever level. So I'll leave it there, other than to say our goal today is to drive home the point that York is a great place to help us ask the right questions involving the right people, produce the right information and make that available to the right groups. And I hope that Barry Wright's talk, who's following me, will demonstrate where actually the research that is available currently in child and adolescent mental health probably hasn't done that, and where we're trying to address that need. And I think that's a recurring theme that you'll see throughout the day. So thank you very much, Barry.
I don't mind. Can you hear me? Does that work? Oh, it's not on. Ah, it is now. You can hear me now. Great. Okay. So hi, I'm Barry Wright. I'm a child mental health, a chair in child mental health at university, but also come from a clinical background. Initially as a GP, then as a child mental health professional. So see it from different perspectives. But also I'm a dad, like many of you, I guess, and so that gives you a whole set of other perspectives as well. And I like to think that I bring those perspectives to the table when I'm thinking about things. I don't have all the answers, obviously, none of us do, but I'd like to think I'm open-minded in pursuing them. I think the first thing to say is that we're going to shine a little bit of a light on child mental health, and particularly a gap in the literature, or gap in the research, which Rachel's partly alluded to. So we're going to focus in a bit rather than taking a more broad view. But that's not to say there's not some really fantastic things going on across the university in a wide range of departments. And we've had collaborations with biology, Department of Chemistry, all sorts of subsections of health sciences, health economics, CRD, psychology are doing some fantastic things in cognition and sleep and deaf children and vision, and the Education and Psychology and Research Centre doing some superb things in education, so social policy, SPRU, social work, doing some superb things around determinants of mental health problems. And there's some fantastic stuff going on in computing and digital technologies around artificial intelligence and gaming and using platforms. And every department is doing something more or less in mental health. Archaeology is doing some great work around how you can take archaeological finds into the classroom and get discussions going around mental health, around cognition, around skin colour and what Cheddar Man may have looked like, and what that means for us in society today. Yes, so we're all doing some really great things. There isn't time to talk about them all. I think the others have already said. Rachel touched on the fact that most of serious mental illness starts before you're 18, and that's very true. Karen mentioned the fact that 11% of funding goes to 23% of the burden of mental health problems. There's another statistic, and that is that of the mental health funding that does come into mental health services in the NHS, 6% of it goes to the under 18 population, the child and adolescent mental health population, and that's 20% of the population. So even though the government talks a lot about prevention and has done for many years, it doesn't really put its money where its mouth is. It tends to go in other directions for all sorts of different reasons. I think there's often good intention, but money will rarely be ring-fenced, and the commissioning system is quite a complicated one, so it often gets diverted. And I guess that's the first thing I wanted to say. It's been a really difficult 10 years for child mental health clinicians, because the numbers of young people coming forward with mental health problems are going up all the time. And there's that would be a whole talk on its own, because we've been looking at that quite carefully. And it's not necessarily all to do with increased morbidity. But the numbers have been going up. There are more young people being admitted to units. for mental health problems. There are vastly more young people turning up in casualty for self-harm. There are more young people coming forward with eating disorders. There are more young people presenting with anxiety and depression, affective disorders. So there seems to be a greater need amongst young people. Some of that may come about as part of some reductions in stigma. There's still a long way to go, but there is more of a conversation going on now about mental health, which is a great thing. But a lot of it may be to do with a whole range of other things, which I won't go into now, but perhaps we could talk about in the break or later on. But there is an increased number of young people coming forward. And it's happened at a time in 10 years where there's a massive increase in reduction in funding, or a massive reduction in funding. There's a big reduction in funding in the NHS to CAMHS. A lot of the CAMHS teams over the last 10 years have had large amounts of money stripped out, lots of team members getting highly stressed, going off sick, very large numbers of team members moving on because they're so demoralised by services. At the same time, you've had local authorities that provide a lot of the baseline services for young people, preventive services, having reductions in youth teams, in learning support teams in schools, behaviour support teams in schools, and all the joined up partnership working that used to happen over long periods of time has been stripped away gradually, because as people have their money reduced, they retrench back to core business. So the joint teams that people set up around looked after children, around learning disabilities, around autism, around youth offending, a lot of those are going by the wayside as people retrench to core business. So you've got increasing need at the same time as reducing resources and reducing services. And it's a catalyst it's a situation for significant problems, really. And that's the context in which we're in. The government's response to that is a paper in 2015, Future in Mind. It decided that the tiered service, which was a sort of cared pathway service for children, wasn't a good idea and that it wanted to dismantle it. So it decided it would take that away. Didn't really say what it would put in its place, which wasn't very good. But just recently they've released a paper, a white paper saying that they are going to fund trailblazer projects where they put more funding into schools. So they've now funded a series of trailblazer projects, not across the whole country, just a small number of places around the country, where they're going to put mental health services into schools. And they're going to train those people up. So they're now designing the curriculum and the courses for 5 or 6 different training sites across the country for these new staff. Of course, that's all very small, and it's happening quite late, and it's going to take about 4 or 5 years for all that to roll out. So it's leaving a lot of problems in the meantime. Why am I saying all this? I'm saying all this because when you're a researcher and you have an eye to the clinical world or an eye to what's going on for your young people, you kind of think, well, there's no point me researching these really clever interventions where you have to see somebody 3 times a week for 2 hours, because no service is going to be able to deliver that. So we need to think about what can we deliver that is going to be cost effective, and that's why it's so helpful to have our health economics colleagues in our teams. And also we need to think very carefully about what young people want. And going back to some of our other speakers, we need to be really careful to make sure that we're not just designing therapies that we think are great because we've got this particular idea. Or what often happens in services is that adult mental health services come up with this fantastic idea, and then somebody says, oh, let's research that in children. And a lot of the interventions that happen in children are really adult interventions that somebody's plonked into childhood. And that's sometimes why they don't work very well. So we've spent a lot of time asking young people what they would like. And interestingly, they don't say, by and large, I would like to sit in a room with a psychiatrist and speak to him for an hour 3 times a week. They just don't really want that. They're not asking for that. And also, they don't really come into the room and say, I'm depressed either, usually, or I'm anxious. They will tend to talk about what their problems are, but they'll be in the context of their real lives, around their friendships, around their social networks, around the stresses that they experience, around the guilt that they feel, or whatever emotions they have. So it's really important that we listen to that story. And if you do look at the qualitative research that talks to young people about face-to-face services, then actually what they often ask for is to be listened to and to be understood, for somebody to know what they're going through, not to follow a paint-by-numbers approach to therapy. And I think we have, unfortunately, and this is a personal view, gone down a bit of a paint-by-numbers approach to therapy in the NHS at the moment with IAPT. where you get a sort of a very formulaic certain number of sessions following a very certain number of ways of doing things that don't necessarily work for everybody. Young people want the therapy to be centred around them. They want to be involved. They want to have some say or some control in the agenda. And they would like it to be more tailored to their background and their culture. You know, there's lots of evidence to show that South Asian people really aren't served by the child mental health services that are out there at the moment. And also, they would like to do things often rather than talking. So they would like to go out and be part of a social network, or meet and join a club, or do an activity with a therapist rather than sitting and talking. And those are the kinds of things that are coming back to us from the young people, which I think is really, really important, and we've got to make sure we listen to it. So what's actually going on around the country at the moment in terms of research centres? What are we doing? We spent a bit of time looking at what different research centres are doing in child mental health. There's quite a few of them doing medication research. That's a bit worrying, because in times of austerity, when you haven't got time to do psychosocial interventions, if you're falling back on medication, that's a little bit worrying, in my view, personal view again. There's a lot of people doing biomedical research, and these are all things we've done. We've done bits of medication research with randomised controlled trial of melatonin for kids with neurodevelopmental problems and sleep problems. We've done biomedical research looking at the urinary excretion of heavy metals in autism. We've done neuroimaging research looking at how kids with Asperger's see emotions on faces, and cognition research with the psychologists around people with Asperger's understanding emotions on faces from a cognitive perspective. We've done all these kind of things. There's lots of people doing CBT research in child mental health. Again, quite a lot of that is borrowed from adult services, a lot of automatic negative thinking, a lot of behavioural activation, those kind of things, social problem solving, without much tailoring. There's some people doing some psychodynamic research, and there's quite a lot of attachment research and systems research. Some great parenting stuff, including at our university with Tracy and others doing some superb work there. And there's some people doing some whole schools approaches. But we noticed when we looked at all these areas of research that there's a gap. There's a really stark gap. And the gap is what the kids are telling us we should be doing. And we're not listening to them. We're doing all this other stuff. What the kids are saying is we want something that's a bit more child-oriented, a bit more friendly for young people and children. So that's where we're trying to open up the door a bit, stick the crowbar in and get a chink of light coming through. It's around child-oriented interventions that are designed for children. How do you do that? Well, I suppose it's partly having the will, but it's also having the kids, what the NIHR calls PPI, patient and public involvement, having young people and talking to them a lot. And one of the things we've been doing over the last 8 or 9 years is whenever we want to talk to children about something, sometimes we'll get them in a room and talk to them about it, but we've had a couple of professional animators who work with young people, and they'll ask them a question. So they'll say to them, get a group of young people with eating disorders together and say, what helped you get better? And they will make an animated film with the young people. The young people will often make models and turn it into an animated film. And we've now got a DVD with 20 of these on it. So I didn't realise we'd done so many, but over the years, with various trusts, including Tees Eskin Weir and Leeds and York Partnership Foundation Trust, which is another trust we work closely together with, and Northumbria and others, we've done many of these. So there's a few of these that people can take at the end. I'm afraid I haven't got very many because people have taken them all, but there's a few if anybody wants to look at any of those animated films. And that's one innovative mechanism of getting PPI. But you also have to have the right team. You have to have a multidisciplinary team. You have to be innovative and imaginative as well. And I think more broadly than just what do we do with adults and will that work in children. And you have to have the right sort of vision. So we have this centre called the Child Oriented Mental Health Intervention Centre, and there's quite a number of people working in it now, and we're trying to get more and more money to do more and more research to open up this particular area of research. What kinds of things are we doing? I've got some videos, but probably isn't time to show you, but I can show some later on if anybody wants to see them at another time. But we're doing a Lego-based therapy study in kids with autism. So we see a lot of children with autism who are isolated and lonely, who maybe find it really difficult to have friendships. Children with autism aren't asocial, as is often mentioned. They do like to have friends. They just make friends in a different way. They tend to have very small groups of friends around particular areas of interest. Lego is a fantastic way of engaging children. At the same time, you can give them a range of skills around social problem solving, around turn taking, around cooperating and collaborating with other children. Tremendously helpful in helping them to build those relationships going forward in the future. And it helps with their learning as well. So we're doing a randomised controlled trial of that. We have another trial where we're looking at one session treatment for phobia. And we're comparing it to CBT as usual, which is what you get as standard in the NHS at the moment, 6 to 10 sessions of cognitive behaviour therapy. We found when we've gone round the 12 trusts that are involved in this study, about 6 of them, the CAM service says that it's not a serious enough problem for them to treat, which I find pretty astonishing. Why do I find that astonishing? Because A, it's really easy to treat, B, it's a lifelong condition, and they're saying it's too mild for us to treat. And that comes against the backdrop of what I said right at the beginning, is that CAMS teams are raising their thresholds and they just can't cope with the milder things that are going on, and yet this is a really treatable condition. And it's very satisfying to see a child who can now go out into the park when they weren't able to do that, or go and see their grandma who has a dog and they had a dog phobia or whatever it may be. So that's a really interesting study. We're doing a range of work around deaf children's mental health. This is, again, an area where there's very little research going on in mental health. We have the only national deaf child mental health service in the world in this country. We have 10 centres in this country for deaf children with mental health problems. There are some countries, there are other places, there are other countries where they have one centre, like 1 or 2 centres, like in America or Sweden, but this is the only country that has a full national coverage. So we're in a really rare opportunity to do some quite interesting, innovative research that nobody else is doing. And we've been looking at mental health in this group. We had a study that looked at mental health problems in kids who weren't accessing CAM services, and 26% of deaf children who use British Sign Language have significant mental health problems, which is higher than the neurotypical population. We've also been doing some work looking at improving autism assessments in deaf children. Autism is diagnosed much later in deaf children, often 5, 6, 7, 8 years later, because people get very confused about how they present in terms of deafness or autism. So we've been doing some research to improve those screening assessments, parent-based assessments, play-based assessments with the child. And we've also been putting in grants to do some early intervention work with parents to prevent mental health problems. We have another NIHR Health Technologies Assessment grant looking at social stories, which is quite an interesting child-friendly intervention where you write a child into a story about themselves to help them to reduce their anxiety about a particular situation. It's very effective for kids with autism who maybe get very aggressive in certain contexts, usually in the context of anxiety, and you write them into a story about themselves that teaches them the thing or explains to them the thing that they really don't fully understand at the moment. And the feasibility trial found that to be incredibly effective, and we're now trialling it. We've got Lena Geiger, who's a reader in the audience somewhere, hopefully, and she's been doing some great stuff with technology, working with digital technologies and other departments within University of York, looking at developing a prototype for a platform for digital games to help young people with anxiety and depression, and another one looking at video capture and digital films, particularly. It's a really clever way of helping children to do some sort of role-play interaction by placing them into a filmed scene and having a variety of different reactive scenarios. So that's quite innovative and quite interesting, and the kids love that. Lena's also doing some work looking at supportive groups for children who like to get together with other young people who have a parent who has a mental health problem, and that's together with lots of charitable organisations. And I think, I don't know if the others have mentioned it, but we do an awful lot of work with a lot of different charities, as well as Mental Health Foundation, which is a fantastic link for us. We're putting in grants at the moment because kids are telling us that they think animals are quite helpful for them in a mental health context. Nobody's really properly researched it. There's some tentative research in America, probably just about enough to get somebody to fund a grant. And so we're going to put a program grant in for animal-assisted therapy for kids with anxiety and depression. And over the last 2 years, we've been looking at the mental health across schools in 21 secondary schools in year 8s and year 11s, so we can kind of landscape, if you like, what's happening year on year to children and young people, particularly as we roll out these new school-based interventions. So there's a kind of a snapshot of where we're trying to head in terms of child mental health, trying to open up this door of child-oriented, child-friendly interventions, trying to think more innovatively. It's not to say we don't want to do the other stuff as well, or that other people shouldn't be doing it. They're all very important things. But we feel that this is a real niche area where we have strength. So I'm going to shut up there, and I've actually kept to time. That's pretty impressive.
We've got a couple of minutes for questions, if anybody has any questions for Barry before we move on to our next talk. Karen.
I wondered about, you said that children prefer to do things rather than, sorry, thank you, Sheila. Yeah, you said that children like doing things rather than just talking about things. I wondered how much that was true for adults with mental health problems as well, whether we knew much about activity-based, maybe not Lego, but you know, other things that might involve activity rather than talking for adult mental health problems as well. Maybe I'm asking the wrong person there.
I mean, perhaps someone else should answer that, but I do personally think that there is growing evidence that there's a whole range of interventions that are activity-based, and I think it's fantastic we've got this Green Space grant, because that's going to open some opportunities up for us to test some of those things. But also, I mean, I do think we should think more innovatively about our mental health engagement in terms of therapy. You know, a ward round for an adult with a serious mental health problem is quite a stressful event. They have to meet several people in one setting, and you know, I think there are a whole range of innovative ways we should be thinking about the kinds of activities or the kind of settings that some of these new grants that we've got will really open up for us.
Thank you very much. Any other questions at this point? Yes, over at the back there.
Yeah. Hi. I would love to know how to get to a balance for the creative people and the technical people to actually get involved with these like therapies, because we've got like the technology and we've got like the creative tools, but we don't necessarily have like a background in psychology or in psychiatry or like these scientific fields. And what tools can we access so we can actually have like a proper foundation, so it's easier for both sides to develop the tools, like the technological tools, and for the like doctors and psychologists and people dedicated to that field to actually feel that this is going to work.
I think there are growing discussions going on, and have been for several years, around those fields, trying to find a common language, trying to skill each other up, and there have been some great collaborations going on. I've mentioned some of them, so I'd perhaps come and talk to me afterwards, and we'll see how we can link up. But I think we're always very keen to build in those innovative disciplines and work together.
It's also worth saying that the Network Plus council bid that we were talking about earlier, Closing the Gap, will provide a really strong opportunity for that kind of interdisciplinary working. So there really are opportunities to really get involved in that kind of thing now. I had one more question from Sue, and then I'm going to move on to the Mental Health Foundation. I thought it was you. Joe, Sue, somebody from TZESC and Weir Valleys anyway.
I'd just like to say that in this time of austerity, the pill is cheaper than the person, and that will always come out, I'm afraid, in health economics. yes, you have such things in adults as drama therapy, but that is quite intensive. They have suggested art or music for people with schizophrenia, but if you've got any other thing, you will not get any funding for it because the money is so tight. So it's a good idea, but I think in reality, at this particular economic time, as service users, we're not seeing it.
I agree with that, but I do think that's where research building in health economics comes into its fore, because if you can show that something's cost effective, then it does become attractive to the funders. So I would always try and...
Cheap.
Pardon?
Cost effective isn't just cheap.
No,
Cost
that's
effective.
right.
Yeah,
That's right.
it's got to work.
But,
Yeah.
And
but
that,
CCGs aren't. They're not. They look at the black and white things. They don't. They really are short term. They're looking to they've got deficit. We have a deficit in ours of Wales between 12 and 18. So they want the win tomorrow, not in 10 years' time, because you're not using the services then. And that short-termism that is seen by the commissioners of health and social care really needs to be removed, and they actually got to get real. But in today's austerity, when you are working up to the day on your budget, that is the question. That's the thing that's got to be changed. You can do all this research you like, but until there's some long-termism in terms of funding and looking at the problems.
your point is really well made, Sue, and it's one that we've been grappling with in our field for a long, long time. And Karen's point about cost effectiveness not just being cheap is really important. But we need the evidence. We need the high quality evidence that actually goes in hand with the cost effectiveness analyses to create a convincing argument for these people before we can actually make those sorts of changes. And so we are trying to work also in partnership with CCGs and other commissioners of care to ensure that we're actually addressing the sorts of questions that they have. But I agree with you absolutely. We're in it for the long game, but part of it is actually getting the questions right. So I hope you can all join me in thanking Barry for a very, very helpful, informative presentation. I'm very pleased to welcome now to the stage our esteemed colleagues from Mental Health Foundation, so Josephine Breedfeld and her colleague Jade, who will be doing a joint presentation on some of the work from Mental Health Foundation that connects with what we're doing here at York and is also broader. And they shall tell you also at the end of that about how we're going to manage our tea break. So over to you. Thank you.
Thank you. Thank you very much. Yeah, well, yeah, that would be great. Sorry? You need to use this. Yeah, for the okay, that's fine. I'll just use that. No, that's fine. Thank you. Wow, great. Thank you very much, everyone, for having me here and having me to talk a little bit about the work that we do at the Mental Health Foundation. And I'm joined here by Jade, who is the research officer at the Mental Health Foundation, and I'm the research lead at the Mental Health Foundation. Really pleased to be here. This is supposed to be a slide. This slide had text, so I'll say what the text says because it's now looks a little bit musical. I'm not too sure. This is us trying to communicate our mission. So our mission is a world for good mental health with good mental health for all, and what we try to. Yeah. Okay. I'll just go to this next slide. So our mission is to help people understand and protect and sustain their mental health. And we really are focused on prevention. So with prevention at the heart of what we do, we aim to try and find and address the sources of mental health problems so that people and communities can really thrive. So we were founded in 1949 by Dr. Derek Richter, who was a medic, and he really set up the organization thinking that there's such a discrepancy in mental health research compared to health research. And I think we're still here today grappling with that, so to say, and to think really why is that the case. And what he also noticed was that there's a lot of inequalities in mental health, and one of the things that he noted was that people living in poverty have poorer levels of mental health, and that's again something still today that we are trying to address. So, as I said, we're still here today. Approximately 5.8% of funding into mental health research goes, or 5.8 of total health research goes into mental health research. And that is about £8 per person with a mental health problem goes into that. But if you look at the spend on cancer, it's 22 times more, and it's 14 times more on dementia. So when we look at prevention, only 5.2% of an 8.6 billion budget into health-related research and development is spent on primary prevention research. And that's just recent statistics, so here we are. I know that Professor Barry Wright told us a lot already about the prevalence. So I'll skip this slide for now, but you can see that there is high prevalence, although I'm not sure where you are with the latest statistics, but I do know that the new children and young people statistics will be announced in November this year, so that will be quite exciting to see whether there is a change in that 10%, but from what we've heard from Professor Wright, there's probably going to be an increase in that. And this really talks about implementation. So we know that young adults, about 1 in 4 young adults with mental health problems seek help, or access help. However, the picture is actually even bleaker when it comes to early help for children with emerging problems. So what it says here, this is a report from the Children Commissioner in 2017, says there is no clear expectation placed on local areas about which services should be provided or how ill a child needs to be before they should receive care. So there's just nothing there for children with emerging symptoms, even though that would be an opportune place to look at prevention and look at early intervention before children go into services, which, is already tricky to access services at that point. So we really enact change through looking at research. We also, so the previous slide didn't work, so I'll just go on to the next one. So we enact change to looking at research. So we really want to look at strengthening the evidence base, but then also policy and public affairs. So what we want to do is when we have that research, we want to communicate that and then communicate that to policymakers and make it into campaigns and really try and challenge the status quo around mental health. We also do quite a lot of public engagement work, so a lot of listening to people, trying to understand what for them are the priorities with regards to mental health and how we can really help to further advocate for change on behalf of them as well. And we deliver programs in the community. So we learn from what works and we try and really help local initiatives to come to fruition and work with partners. So what sets us aside from other mental health charities, for example, is that we're not a service delivery organisation on the whole. So we're not like Mind, for example, who delivers services on an ongoing basis. We try and test and work with partners and then hope that the interventions that we develop will be picked up by other organisations, by policymakers, and taken up into routine practice. So that's really where we see our role. So we improve mental health across the life course. So what Professor Gilbody also already said was that we really try and improve mental health across the life course, and we take a similar approach in that. So looking at childhood, working age, and later life, and acknowledging that there are different points of pressure and also different types of interventions that work for the different life stages. And what I'll do now is I'll really talk about, I'll have lots of videos. I do hope that they work, not the slides, but I do hope that they work. And And just to give you a flavour of some of the work that we do, so it's a bit interactive, I hope. So the campaigns that we do are, so I'll talk a little bit about the campaigns now. So the campaigns that we run are, I'd wait.
Okay, yeah.
Because if you click, it goes.
Okay.
Yeah. It's okay. So the campaigns that we run are on an annual basis. We run sometimes 2 and 3. And what's really exciting is, as part of the partnership that we are developing now with the University of York and also the Cochrane Centre for Common Mental Health Disorders, is that we might want to look at doing things together and work in partnership and do joint campaigns, because we have found a lot of issues that we share kind of commonalities with, and that we both really care a lot about and that we want to advocate for.
We asked, how are you feeling? But how are you really feeling? I think I would say I'm fine, I'm okay, just not to get into any details.
I would say, fine, thank you.
I'm fine.
Why? Because sometimes we don't want to tell other people how we are actually feeling, because we don't want to be judged, or we don't want to burden them with our problems if we aren't feeling well, or we're afraid to tell them how we're actually feeling. But I do believe we should be honest with our feelings. I feel that how I feel affects other people in my life, and I'd rather temporarily give them an answer that would be more uplifting.
Usually I'd say I'm fine.
I'm good, thank you. Fine.
I'm fine.
Many times I've found myself in my life that I've had to pretend with people. It's not their fault, a lot of it, but I've had to pretend with some people so as I don't let them, just maybe some of them, like I said, maybe some of them wouldn't understand, and probably I don't expect them to.
I'm fine, thank you. I'm fine. Sometimes people ask you how you are, but they don't really mean how are you. It's just sort of a thing they're saying, as like hello or whatever. But if someone really wants to know how I'm feeling, I will tell you. I would just say I'm fine.
There's nothing more boring than hearing a list of ailments from somebody when all you really need to know is whether actually he's okay or she, or whether there's anything that really he or she really wants to talk about, which is seldom in terms of casual retreats.
If it's a sort of ritual, cliche kind of conversation, you're passing somebody in the corridor at work, then you just answer what you answer, and it's usually positive. Fine, everything's wonderful in the world.
So that's one of the campaigns that we ran, and we got quite a lot of coverage on that. And this really just helps to, or what we aim to do with this is to try and tackle the kind of usual thing that we say when you ask someone, how are you? And you say, I'm fine. But actually, are you really fine? And sometimes it's just worth asking it again to say whether someone's really okay. And sometimes that can make a difference. So another one of our annual events is Mental Health Awareness Week. And what we do during this week is we pick a theme, a topic, and we really try and raise awareness for that. So there are 2 big mental health events in the year. We have to say that. One of them is World Mental Health Day, and the second one is Mental Health Awareness Week. So for Mental Health Awareness Week, this is something that the Mental Health Foundation hosts. So we actually have the opportunity to influence an international audience with what they should be talking about and what we should be raising awareness about, but also what we would like to change. So we always come up with a set of policy asks as well related to the topic that we're advocating for. So I've got another video.
The pursuit of health and happiness. It's an endeavour we're all involved in, to some degree at least. We often make our bodies the focus, but there's a big part of the puzzle that is missing. We are made for community, to be connected with others. In fact, we can't thrive in life without good relationships. But the reality in Britain is that we're more isolated than ever before. living longer, often disconnected from family, with increasingly virtual friendships. And having a sense of community is more and more rare. In fact, statistics show Britain is the loneliest place in Europe. And this isn't just about being alone. Having toxic relationships is just as damaging, and both can lead to depression. A quarter of us say we don't feel emotionally connected to anyone else, and 1 in 4 of us experience mental health problems every year. Not being connected to others can be as bad for your health as smoking 15 cigarettes a day. It can lead to higher blood pressure, poor sleep, damaged immunity, and put us at significantly higher risk of developing certain diseases. It doesn't need to be like this. Being in good relationships is vital to your well-being, and at the Mental Health Foundation, we believe there is an urgent need to make better connections with those around us. If you are pursuing greater happiness, we suggest you start by investing in the people in your life. We can all do something every day to change bad patterns, connect with those around us, and improve the quality of our relationships. It's not rocket science. We need to be connected. So whether it's the man at the bus stop, the lady who lives upstairs, your dad, your old school friend, or a colleague at work, there is someone you can connect with right now. Find out more on our website, mentalhealth.org.uk, and change your world, one connection at a time.
So this is another example of some of the work that we do. It's very much focused on communications, very universal, so it's definitely something that we try to raise awareness for, but it's not all the work that we do at the Mental Health Foundation. So we also run programs in the community. So for example, the Scottish Mental Health and Arts Festival, where we deliver over 300 events and reach 25,000 visitors each year. It's a way to explore mental health through the arts, and it's actually been replicated internationally, and we're also looking to bring it to other cities in England. So maybe York is next. Another project that we run is related to children and young people's mental health, and it's a whole school program, but it's a peer education project, and we work together with schools to deliver a program for year 12s to then deliver lessons to year 7s, and it's currently been delivered to 8,000 students and delivered in 43 schools. So I guess that speaks to one of the strengths at the Mental Health Foundation, is that we can pilot something, we can implement it quickly, but we also need to very much ensure that it adheres to the evidence base and research. And this is why we're really excited to be here, to be partnering with the great colleagues here at the University of York. And our role in research is really, in the research team at the Mental Health Foundation, is to try and bring things together, ensure things are evidence-based as best as we can. And we have a team in Glasgow, we have colleagues in Belfast, Cardiff and London, and so we run different types of research studies across the UK. We very much work in collaboration and partnership, and very pleased to be part of the Networks Plus call on closing the gap, and also the partnership agreement with the Cochrane Centre for Common Mental Health Disorders. So what we also have is we have a research collective who informs our work. That's a collective of 12 researchers with lived experience who talk to us on a regular basis to tell us what we're doing and what we're not doing well. And we also really inform the research associated with programs and try to collaborate with academic partners to ensure that what we do also very much contributes to the scientific literature, because that's also why we were set up in 1949 by Dr. Richter. So now I'll hand over to Jade, who so we've got a couple of publications, but I'll hand over to Jade, who is very kindly agreed to talk about her own experience, and also how her experience helps to inform mental health research. Is that?
Yeah, sure. Thank you.
Okay.
Hello, everybody. So thank you, Josephine. I'm Jade, and I'm the research officer at the Mental Health Foundation. So I'm going to talk a little bit about the importance of lived experience in mental health research. So why is it so important, firstly? If mental health research is to be of value, it needs to be focused on the needs of people who actually have mental health problems. People with lived experience can offer their unique perspective and their insight, and that can ensure that research is practical, relevant, and actually leads to real health benefits. Their involvement can also serve to humanise research and to remind researchers what matters. So involving people with lived experience in the research process is very much part of the Mental Health Foundation's ethos. So we believe that if you harness lived experience as lived expertise, it can be used both to improve care and improve overall the general mental health of the country. So I'm just going to talk a bit in more detail about how lived experience can inform mental health research. So one of the key ways in which it can is it can actually help to identify what the priorities in research should be. And that's particularly relevant given that mental health research is underfunded, as we've cited many statistics demonstrating that. Often research ideas come from researchers themselves or health professionals, and these might not always reflect evidence of need. So actually utilising lived experience, co-producing, involving people's lived experience at an early stage of the research process ensures that priorities are focused more on the needs of the people who use these health services. Lived experience can also improve the quality and the appropriateness of the research that is conducted. So it can help to embed research findings into something more real, into the real world setting, so it becomes something that's practical, that can be used practically rather than being confined maybe to a report that's rarely referenced to. Lived experience involvement can also help to avoid wasteful or pointless research. So for example, one way in which health research can be wasted is when completed research is not published. If the results of research aren't made publicly accessible to other researchers or end users, then that does not contribute to knowledge. So as we mentioned before, this could then improve the quality of and appropriateness of research. So incorporating lived experience into research can improve that, and that can increase the likelihood that research is published or disseminated appropriately and that its findings are used. And I think the importance of lived experience is reflected in the fact that it's becoming increasingly a prerequisite for funding. So most national and international research funding programs require some sort of lived experience involvement. And so that's actually really important in terms of driving forward innovation in mental health research. So the next section is really, as someone with lived experience of depression and anxiety, which actually peaked while I was at university, it's been kind of interesting to reflect on sort of how that experience has helped me as a researcher in mental health. So one of the things that I think it has sort of fostered in me has been a sense of empathy and compassion for others that may be experiencing mental health problems. And this is very important as a researcher. It is valuable at all stages in the research process, and it means that your research is driven by a sense of integrity and conducted in an ethical and moral way. If you're out conducting field work, so for example interviews or focus groups, an empathetic approach is really, really important to get a rapport with the people that you're talking to make them feel at ease, and that in turn can then improve the quality of the data that you're collecting. Another thing is my own lived experience fueled in me a curiosity. So I wanted to learn as much as I could about mental health and how it could sort of have such a huge impact on my own life. I think living with a mental health problem is something that feels that it is an incredibly individual experience. So as a result, I became much more curious to find out how other people experienced their world or their mental health problem, and to see what the similarities and differences are across these experiences. And I think curiosity is something that's incredibly important for research. It's the driving force behind innovation and creativity. And finally, my lived experience made me incredibly passionate about the need for high quality and impactful mental health research. As we've talked about before, research should not be something that's remote and distant. It should actually translate to real health benefits. And having lived experience makes me routinely question the work that I'm doing to check whether it's actually adding value and whether it actually has any practical relevance. And this has also motivated me to develop as a researcher, and I'm constantly eager to develop my skills and expand my knowledge. So I feel very fortunate to be working in mental health research. I take pride in the work that I do, and the fact that in some way I'm making some sort of impact in an area that's very important to me. So on that note, I think we're moving into the tea and talk. So thank you.
Thank you, Jade. Oh, thank you, Jade. I think that says it all. Yeah, thanks very much for that. I'm mindful I didn't talk much about the partnerships that we have, but I'd be happy to tell more about that in one of the breaks. I mean, we have international partnerships, European partnerships, and through our collaboration we can kind of share those connections as well. And we also are very well connected in the UK landscape with regards to mental health. So, moving on to the tea and talk.
Do you want to introduce this?
Yes, absolutely, or we can do it together if you prefer. So the tea and talk. So the Mental Health Foundation at the moment, at today, 2,800 tea and talks are being held across the UK. So it's yay. And we're one of them. So it's great to discuss the tea and talk in a little bit more detail. So as part of the tea and talk, we want to really know from you what the priority issues and questions are for you with regards to youth mental health research. So you've listened to all of the things that we've been saying to you today and all the kind of information that we've provided, some really great talks. So that would be the question, and I really hope that you'll have a coffee, have a cake, reflect on what you've just been listening to today. And we have a form, and it would be really, really helpful if you could write down what for you, and also at the end kind of say a little bit about what kind of attendee you are, so whether you're an undergrad student or a postgraduate student. So write down for you what would be the most important thing to address, because as we've said, we really want to listen to you and what your priorities are.
Thank you very much, Josephine. And just to say, we have Mental Health Foundation has a stand outside and some materials, as does the Cochrane Common Mental Disorders Group. And we've also been lucky enough, I believe, Philip, to have some YouTube videos from some of the other work that's going on throughout York that we'll be showing on one of the walls outside.
Yeah.
So please do have a look at these, and please also fill in some of the questions, even if it's only one question that's a top priority for you. We're really interested to hear your views about what you think we should be doing in this space, and there'll be an opportunity to hear also from the speakers that we've heard from before tea later on at the close of play today about what their particular priorities are in this space. So enjoy your tea, and please do get around all of the stands and the information that's available. And please join me in thanking our speakers today. Thank you. Okay, are we all right to get started? Hi everybody, thank you so much. Thank you so much for coming back. I hope we managed to get some more people back in the room now, because we have a nice afternoon, which really I hope demonstrates the possibilities and opportunities offered by this university and other universities for people who are interested in career development in this area of research. So we've got three very nice quick presentations this afternoon. The first one by Mary Barker, who's a second year PhD student in Social Policy Research Unit. We're particularly keen to help think about ways that we can develop careers for PhD students across the board, and I hope you'll see that reflected in the programme this afternoon. We've got several PhD students and also a lecturer who's working in the area of mental health, giving presentations about their specific areas of research. So I hope you'll see some build-up in terms of what we can achieve if we give people the right support at the right time. So with that, I'd like to welcome Mary Barker to the stage to give her presentation on anxiety, depression in young people with life-limiting conditions. And of course, we have quite a feature in this area of work in York. Thanks, Mary.
Hi, so yes, I'm Mary, and I'm a second-year PhD student in the Department of Health Sciences. And I'm going to talk to you today about my PhD project, which is looking at anxiety and depression in children and young people with life-limiting conditions. So, as many of you will know and have heard today, mental health problems in children and young people is a growing public health concern. So, of 5 to 16-year-olds, 10% are diagnosed with a clinically diagnosable mental health disorder. And two common mental health problems are anxiety and depression. So, in the last survey, 3.3% of 5 to 16-year-olds were found to have anxiety and 0.9% to have depression. Now, as I said, I'm looking at children and young people with life-limiting conditions. So this umbrella term constitutes two different types of conditions. So life-limiting or shortening conditions, where there's no reasonable hope of cure and from which children and young people will die, for example, Batten's disease. And life-threatening conditions such as cancer, where curative treatment may be feasible but can fail. So as you can imagine, living with these conditions can introduce many challenges to the life of a child or young person. For example, fear of prognosis and whether the child is going to die, frequent treatments and hospitalizations which can disrupt their presence at school, and their peer relationships with their friends. And this, as you can imagine, can make them more vulnerable to mental health problems. So specific studies and specific life-limiting conditions such as cystic fibrosis and HIV have found a higher prevalence of anxiety and depression in these children. However, what hasn't been done before is the pooling together of these studies to see what the epidemiology of anxiety and depression is in this population group, to see what kind of need there is out there for psychological support. So therefore, I conducted a systematic review to assess the prevalence and or incidence of anxiety and depression in children and young people aged 5 to 25 with a range of life-limiting conditions. So I searched 3 databases, Medline, Embase and PsycInfo, and screened over 14,500 articles. From these, I read the full text of 709 articles and included 36 studies. With these studies, I conducted a meta-analysis. So this meta-analysis made me be able to calculate pooled prevalence of anxiety and depression. Now, this is a weighted average of the prevalence of anxiety and depression from those studies, weighted by the sample size of each study. So if a study had a higher sample size, it was given a higher weighting in the meta-analysis. I then also looked at different factors which could influence that prevalence, such as the type of life-limiting condition the child was experiencing, the mean age of the sample, and the location of the study. So from the 36 studies, these were some of the key study characteristics. So a lot of them were conducted in the USA, 18, 14 in Europe, and 3 multinational studies. There were quite a few different types of life-limiting conditions, and some of the most common were cancer, cystic fibrosis, and HIV. The sample sizes varied from 20 to over 2,000, but the median was quite small at around 59. The mean age also varied widely from 11.1 to 20.7 years. And of these 36 studies, I looked at the risk of bias with a tool that was specifically designed for use with prevalence studies. So none of the studies were deemed to be at high risk of bias, 25 at moderate risk of bias, and 24 at low risk of bias. And there were many, many different tools used to assess anxiety prevalence and depression prevalence. So 19 tools for anxiety and 20 tools for prevalence, showing the variability in the studies. So first of all, here are my results for the anxiety meta-analysis. So there's 20 studies here, and over 4.5 participants were included. So this is a forest plot, and for each of the 20 studies, there is a black diamond and confidence interval showing the prevalence estimate and confidence interval from the study. At the bottom is the pooled anxiety prevalence, so the diamond and the corresponding red dotted line. So the pooled anxiety prevalence was 18.7%. So this is a lot higher than the figure I said for the general population at the beginning, which was 3.3%. The width of the diamond corresponds to the variability or heterogeneity between studies, and this was very high at 91.8%. As you can see, I've grouped the studies by type of life-limiting condition, and there does seem to be some variability by the disease group. So thalassemia has the highest pooled prevalence estimate. However, the diamond is very wide, so there's a lot of variability between those studies. Here are my results for depression. So again, a prevalence estimate for each study. So there's 35 studies in this one, and over 6,000 participants. The pooled prevalence estimate, the dotted red line, was 13.7%, so again a lot higher than the 0.9% for the general population. But again, a lot of variability between the studies. If we just go back. So, the meta-regression. So after I'd done these meta-analyses, I looked at different factors, as I said, which would significantly affect the prevalence. So for anxiety, it was found that the assessment tool used was significantly associated with the prevalence of anxiety, with diagnostic interviews being associated with a higher pooled anxiety prevalence than self-report tools. However, for depression, this was not found, and instead, age was significantly associated, with older age significantly associated with a higher pooled depression prevalence, which is something we see in the general population. So, to conclude from my meta-analysis, there does seem to be a higher prevalence of anxiety and depression among children and young people with life-limiting conditions as compared to the general population. And this does seem to vary by factors such as life-limiting condition type, age, and assessment tool. And this indicates the need for psychological support among these children to try and reduce the prevalence of anxiety and depression in this patient group. However, the current research has focused on a very narrow range of life-limiting conditions. So there were only a few which looked at neurological diseases, which are a very large proportion of life-limiting conditions, but they're also a group where it's hard to measure and assess anxiety and depression in. So this presents problems that further research needs to tackle so that we can look at a more robust estimate of what the prevalence of anxiety really is. So my next steps will help contribute to that. So at the moment, I'm conducting a systematic review to look at the risk factors for anxiety and depression prevalence in this population. And then I'm going to go on to do quantitative analysis of primary care data from the UK to see what the prevalence and incidence estimates are in this data set, how that has changed over time, and what factors are associated with that. So those are the next steps for my 2 years, and from that I'll hopefully be able to gain a more robust estimate of what the epidemiology is like, which children we can are most at risk for these problems, and where to put the psychological support. Thank you very much.
Thank you very much, Mary. Any questions for Mary? Fascinating talk. Of course, dear to my heart because it's systematic reviews. Dean.
I just wondered if you had any thoughts of why the diagnostic interview led to a higher prevalence. Often it's the other way around. The self-reports give you a higher prevalence than the diagnostic interviews. Have you got your head around what might be going on there?
Yeah, so there was a lot of it looked like there were associations between the tools used and the conditions for which they were used with. So as I said, thalassemia was associated with a higher prevalence, and the thalassemia studies were a lot smaller, and so they were able to be, the children were able to be assessed using diagnostic interviews. So because there weren't enough studies for me to be able to put multiple variables into the model, it wasn't clear which one was more significant. Because although the assessment tool wasn't a significant predictor for depression prevalence, the opposite trend was seen. So it could be that the type of life-limiting condition actually has more of an effect than the tool.
Hi there, Mary. Super presentation. It sounds like you've got a really exciting PhD. So you've done a systematic review, so you've looked at papers. So perhaps you could tell us what your next stage is, maybe opportunities to talk to kids with life-limiting illnesses ask them about their anxiety and depression.
So plans to talk to the actual children?
Yeah.
So when I started on my PhD, I was planning to do these 2 parts of the systematic review, and then look at the quantitative analysis, and from then do qualitative interviews. But I'm not sure whether it will definitely go that way. I do definitely plan to either talk to, or hopefully talk to children and young people or physicians. So once I've looked at the primary care data set to see how those prevalence estimates vary, and maybe have some focus groups to talk to physicians about why there might be underreporting or overreporting or differences from the studies, to try and explore how psychological problems are kind of looked at in this population group.
Excellent. Thank you very much, Mary. We're limiting to 2 questions because otherwise we won't get through what we need to this afternoon, but that's really, really fantastic. Thank you very much. Always important to have those views when you're interpreting systematic review data. So next presentation, I'd very much like to welcome to the podium Samantha Gascoigne, who is a final year PhD student and also a research fellow. So again, demonstrating the possibilities for career development, and I believe you also work in terms of trial coordination as well. Yeah. So lots of really useful experience there. And I think this is a very important talk in terms of thinking about sometimes the difficulties in engaging people with severe mental illness, or indeed any kind of mental health problems in research activities. So over to you.
Thank you. So yes, I'm a final year PhD student and due to submit at the end of the month. So I've just chosen a snapshot of my PhD to share with you today. So just a brief background. People with severe mental illness, SMI, are more likely to contract disease such as bloodborne viruses, HIV, hepatitis B, and hepatitis C, compared with the general population. A review done a couple of years ago by my supervisors found that rates of HIV in people with SMI were around 6% compared to 0.6% of the general population in the USA. One of the reasons suggested for this within the literature, there is a sparse amount of literature, there's not a lot out there at all, is that people with severe mental illness are more likely to engage in what's termed high-risk sexual behaviours. So this is unprotected sex, whether that's vaginal, anal, oral, multiple partners, trading sex for things like accommodation, drugs, alcohol, or also using drugs or alcohol prior to or during sex. However, there's no data on this in the UK at all, and there's also no prevalence data. But what I did do, I'll just briefly mention, was a systematic review looking at rates of engagement in sexual risk behaviour that compare people with SMI and the general population. And 10 behaviours were reported, similar to the ones that I've just mentioned, and it all went in the way of people with SMI are more likely to engage in those behaviours than the general population overall. So, like I say, no data on this in the UK, very little research done worldwide, even less done in the United Kingdom. So my PhD was starting to unpick and have those conversations. So we did a feasibility study, of which, interestingly, was one of the first studies that had to navigate the NHS ethics route, looking, specifically asking really explicit questions around sexual behaviour. So that was interesting, but we did get through with that. So the overall aim was to undertake a feasibility study to examine recruitment processes and get participant feedback on the acceptability of a sexual health interview. again, to assess the feasibility of undertaking a study of sexual risk behaviours by, and we did this by number of people approached, number of people eligible, number of consents received, and number of completed interviews. And as part of that, as part of the measures, we collected whether it's acceptable to be asking people in the UK with severe mental illness about their sexual health. Secondary objectives was, we can't force people to answer these questions, so it was a question of they were given the option. If you didn't think this was appropriate, then they could quite just tell me that they didn't want to answer those questions. So we looked at the completeness of the data collection tools as well. So I plan to recruit 10 people from a community mental health team in South West Yorkshire. The initial plan, the inclusion criteria, was people over the age of 18 and on the caseload of a community mental health team with a diagnosis of SMI, so schizophrenia, other psychotic delusional disorder or bipolar disorder. Exclusion criteria included adults with a primary diagnosis of substance use, primary diagnoses of cognitive impairment, those who lack mental capacity, non-English speaking participants, it wasn't within the realms of the study to translate the data collection tools. And one of the suggestions actually from the NHS Ethics Board was to add those on the sex offenders register as an exclusion criteria. So that was added in as well. So in terms of method, it was one 60-minute interview that included four sections. So that was basic demographic information. And then some of you in the audience will be aware of the NatSal. It came about in the time of Margaret Thatcher and was a big block about asking the general population about their sexual health in the 80s. But I think it was the Wellcome Trust did fund this and have been funding this ever since. So this is asked a bit like the census to everyone, a section of the UK population. So I use part of that. It's quite a big document, but there's questions around contraception, a first sexual experience that I picked out of that was relevant to my PhD. And then also I collaborated internationally with colleagues in America who developed a gold standard interview schedule that is specifically looking at sexual risk behaviour. So that was incorporated into our data collection tool as well. And then, as I mentioned, just acceptability data. Is it okay to ask people with severe mental illness in the UK about their sexual health? Did they feel the questions were relevant? The length of the interview, and the nature of the questions, and just their comfort throughout that, just to try and give us a clue with moving forward in this research area. So, summary findings in terms of those approached. Numerous recruitment pathways were needed to approach these participants. So this was either done by their care coordinator, by handing out information packs. So 5 people received information that way. I and colleagues within the CRN, the Clinical Research Network, approached people directly in clinic to hand out information. We mailed out using Professor Gilbody's health and wellbeing cohort to 30 patients, and one person found my information somewhere and reached out to me and wanted to be involved in the study. So of those 76, I received 13 consent to contacts, and after further discussion, that didn't save, 7 declined to participate, and 6 interviews were completed. And out of those 76, that's around an 8% yield. So for mental health research, that is usually what we expect, around 10% response. So in terms of the acceptability, all of the patients, participants felt that the length of the interview was just about right. Majority of them felt comfortable throughout the interview. One said they felt somewhat uncomfortable the first time that they'd ever been asked these sort of questions before. The environment that they found themselves in, so these were either done in a hospital location or in their homes, they felt felt that the environment was safe and supportive. It was convenient for them. They felt the questions were of relevance, and they'd never been asked these questions by a member of their clinical team before. And in terms of completeness of the data set, all questions relevant to their sexual lifestyle were answered. So no one refused to answer any questions. So yeah, that is my feasibility study. Any questions?
Very much, Samantha. So, fascinating study again, sort of thinking about the direction of causality based on our considerations of Mary's presentation earlier on. We need to think sometimes about, you know, what direction mental health, what's the direction between mental health and physical health issues. And so, any questions for Samantha? Josephine?
Hi, that was a really interesting presentation. Thank you very much. I just wondered, do you know what you think the next steps will be? Do you think you might incorporate it into some kind of prevalence survey, or do you think, I guess I just wonder what your views are.
Yeah, I think in terms of a UK perspective, we need to attempt to get some prevalence data. We don't know at the moment whether it is an issue in the UK or whether it is, you know, more internationally. So yeah, I think to be able to move this research forward, I think we do need to start looking at prevalence.
James.
Samantha, an excellent piece of work, and I'm particularly delighted to see work that might confound some received notions or expectations about people's willingness to talk freely about their sexual lifestyles. I'm wondering what you encountered in terms of talking to clinicians about the study, whether they had some reservations, because we've certainly found that clinicians have reservations in asking people about sexual dysfunction for a different study. I'm wondering if you similarly found that the clinicians were more pessimistic about the prospects of your success than actually what was delivered by the participants.
Yeah, so I spent a long time trying to engage with teams prior while the ethics process was going on, because I joined at a point of HRA approval. So it actually took me 9 months to get HRA approval from REC. So I spent a lot of time engaging the team in Swift. But when it came down to it, they weren't prepared to hand out that information to their service users. So I changed my PhD as a result of that. So actually the next section of my PhD was to go to the staff and explore their reasoning behind that, and reasons why, you know, they weren't comfortable to discuss this. And what came out of it really was, you know, these patients are vulnerable. You know, discussing these things is going to be triggering. Discomfort talking about just sex in general for themselves, a fear of coming on to patients, thinking that staff are coming on to them. There was all manner of different reasons, but no evidence in the international literature to say that this has ever been experienced. So it didn't sort of matter, and I went through all of that when I did the training with the team. But obviously at the point of delivery, they weren't prepared to hand this information out to patients.
By getting in the evidence you've got so far, you're opening a door for both yourself, but for other researchers in the future to really tackle this. You know, it's the great good. So thank you.
Thank you. Thank you very much, Sam. Excellent presentation. So a final one from an early career researcher, Dr. Lucy Faulks, who joins us from the Department of Education. Lucy's a lecturer in psychology and education, and again, I hope showing the breadth of some of the mental health research that goes on across the university, not just in health sciences or in our departments, but elsewhere. We know sleep is very important in mental health, and Lucy's come to talk to us about the work she's done with students. Thank you. Maybe, yes. Oh, actually, I'm just going to go back because it's on a timer. I don't know why that function exists. That's useful.
Okay. I've just given this talk earlier this afternoon in my own department, and that one was an hour long, so I need to remember that this one is the 10-minute version. Okay, so it's about sleep problems in first-year undergraduate students who are very much still adolescents, if you're wondering how this fits into a young people afternoon. So they're 18, 19, 20, very much what we would consider adolescents. So before I start talking about the study, actually, I imagine everyone here has an undergraduate degree, most people, or maybe going through one at the moment. Are there any undergraduates in the audience? A couple? Okay. So I invite you to either think back to when you were an undergraduate in your first year, which is possibly very recently, and think about what your sleep was like. Did you have good quality sleep when you were a first year undergraduate in halls? So up to 60% of university undergraduate students report poor quality sleep. So we would define that as a short duration of sleep, or maybe disrupted or unsatisfying sleep. And this really matters. So it matters from an educational perspective, because poor quality sleep is associated with worse academic achievement, but also of particular relevance for today. Having sleep problems can have a causal role in the onset of mental health problems. So they don't just co-occur with mental health problems, but the sleep difficulties can actually come first in all populations, but including undergraduate populations. So my question here, I was interested in, is there something specific about being a first-year student that can cause or aggravate sleep problems? So are these young people who would have sleep problems wherever they were? Did they have sleep problems before they started university? Or is there something about the environment of being at university, being a first year, that aggravates sleep problems? I won't go into the method because of time constraints, but I interviewed 15 first year students and conducted a thematic analysis on the interview. So very briefly, I read through the transcripts and identified themes in the data that seemed to be particularly important. So firstly, I'll talk about what the nature of their sleep problems were. For most of them, the real issue was falling asleep, so staying awake for a very long time at night before they fell asleep. And then also they would tend to compensate for that in the day. So they would either sleep in very late in the morning or afternoon, or they would nap in the day, or both. So then the word cycle came up a lot. So they, what tended to happen is they stayed up very late at night, they slept in the day to make up for it, and then the next night they couldn't sleep again. So really what I was asking in this study is, what aspects of living on campus, of being a first year student, cause these two problems? What is it about being a first year that might make it harder to fall asleep, and that might make it easier to make up for your sleep in the daytime? So I'm going to go through 3 causes that seem to come up from what the participants said, what these first years were. And it's worth saying, sorry, that they had sleep problems, so they self-identified themselves as having a lot of difficulty with sleep. So the first one was noise. Halls are noisy. It's especially in the older ones, there's an awful lot of difficulty with noise preventing you from sleeping. This is one quote. "There are 5 guys in my flat, and they'll just be up every night, screaming and shouting, playing games, and then they run between each other's rooms, so you can hear the stairs, you can hear the slamming doors." So if you can imagine that, not the undergraduates, but for other people, if this was happening in your own house every night, how this might affect your sleep. So the obvious thing is, when people are making a load of noise, you think, okay, well, why don't you do something about it? At York, there's a specific policy in place that if you're hearing noise after 11 at night, you can call the porters, you can call the security, and they will come round and tell people to be quiet. And some of the students I spoke to said they did use this and that this was effective. But a lot of them were really reluctant to do this, actually. Here's a couple of quotes. So it's just a bit of a dilemma, because I don't want to come across as a proper nerd who doesn't want you having a party. I've come very close to calling the porters, but you kind of just don't want to be that person. So there was a lot of kind of social stigma and social issues about reporting your peers. The other option is, why not talk to your flatmates directly? Well, again, for the people who had good relationships with their flatmates, that was possible. And some of them said, someone said, "I love my flatmates. I think that's why the noise doesn't bother me." Someone else said, if they had an early start, they could say that to their flatmates, and everyone would try and be quiet that night. But for the people who didn't get on with their flatmates, this wasn't an option. And this is one quote. "Well, I could try asking them to be quiet, but honestly, it's not worth it. I mean, I could tell them, 'Could you please shut up?' Or I could be like, 'Sorry, I'm trying to sleep.' And they would be like, 'Oh, I'm sorry,' and then continue shouting. I don't trust them to listen to me." And again, if you can imagine, once you're beyond university, living in a house with people that you have this kind of relationship with, and how that might impact on your sleep. So there was a lot about noise and about other people causing noise and about not being able to ask other people to be quiet. But actually, flatmates and your other peers disrupted sleep in another way, and that was because people liked socialising and they liked going out with their friends and their flatmates. So the obvious one is about going out and drinking. So one person said to me, I didn't realise, but at university you don't even go out till midnight, and then you come home at 5 and the birds are singing. So obviously, if people are going out at this period of time, then they're not going to be sleeping. But also if they're drinking, then obviously we know that alcohol is really disruptive for sleep. It wasn't just about going out and drinking, actually. There was lots of other instances where people would stay up really late just talking to their flatmates, or they'd go out into the courtyard if they couldn't sleep because their friends would be out there, for example. But what was interesting is they seemed to know that socialising was bad for their sleep, but they were willing to do it anyway. So this person said, I think the ruined sleep is worth the social sort of thing. I don't really mind because, yeah, I'm anticipating it. I know that if I drink, then I'm going to have a bit of a crap night, but it's more like having fun and being around people, because I'd rather do that than be like, sorry guys, not drinking and staying in. And someone else said, well, I love socialising, and I think if there's something happening, regardless of the time, I'll want to do it, and probably will think I can stay up for an extra hour. I'm very good at convincing my present self to not care about my future self's lack of sleep. And this is really interesting. And if we think about adolescence as a key task of adolescence in that developmental period is to establish yourself socially, to make friends and to fit in. And it's a really important task about being a first-year student. And we know that actually if you have problems with your flatmates when you move to university, that's a key predictor for whether you'll drop out or not. So actually it kind of makes sense in terms of their biological and social development, but also in terms of the fact that they're first years, that actually socialising is important, even if that means you have to make the decision to sacrifice sleep. So those were the kind of social factors that came out. But the last thing I wanted to talk about is more to do with the academic side of things causing sleep problems. And this was about having an independent routine. So for the first time you move to university, it's a really unusual time in your life when you have an immense amount of freedom to plan your time. And with the exception of some courses that have lots of contact hours, for lots of students with fewer contact hours, it's this 3 years where your sleep is sort of completely untethered by a routine. And actually what really came out was that isn't necessarily a good thing. So the first point was that people tended to work very late at night. So someone, they wouldn't start working until after dinner, for example, and then just work as long as they could. Someone said that they had pulled an all-nighter before and they were exhausted the next day. So they now have a clear cut-off in the evening for doing work. And that cut-off was 3 a.m. But this was really surprising, actually, the effect of having few contact hours. So this person was talking about they only had one thing that day from 2 till 4 p.m. And she said, I think you're kind of programmed to think if I'm not in university and I don't need to be there till 2 p.m, I'll just stay in bed till 2 p.m. But then I think that has a knock-on effect that night because then obviously you don't sleep as well that night. So obviously this is something quite unique to being at university where you can just sleep in till 2 p.m. if you want, and then the obvious knock-on effect of that. And the last point I wanted to make was that having this independent routine where they're kind of setting their own schedules, don't have a lot of contact hours, means a lot of undergraduates are spending all day in their bedroom, including working in their bedroom. So anyone familiar with any kind of sleep hygiene advice? It's kind of sleep hygiene 101 that you don't work in your bedroom, and yet this is what a lot of undergraduates are doing. And I think this nicely captures that issue. So she was talking relative to at home when she used to go to school. At home, it's so separate, whereas at university, it's just like turning around and, okay, I need to get into my zone of going to bed now. And then that's really difficult to do. I would love to talk about a lot more of this, but in the interest of time, I'll conclude there and say what I found most striking about doing this study actually was that fundamental aspects of going to university, so about living in halls, about setting your own academic routine, those are kind of key, that, you know, the whole fundamental aspect of going to university, those very things seem to be putting students into an environment that enables or aggravates sleep problems. And that really matters when we think about what having sleep difficulties can put you at risk of. So finally, I think if we're going to try and minimise the risk of sleep problems in first-year students, which I think we should, then we need to think about the unique aspects of first year and about the campus environment and whether we can do anything about it. Okay, oh, sorry. Thank you to my department. Thank you to my department, to my collaborators Alice and Dean, and the participants for being really open and honest about what's quite a personal problem. So yeah, thank you.
Stay here because you might have some questions. Thanks very much, Lucy. That was really fascinating, and I've got lots of questions, but I suspect that there are people in the audience who should be asking them. So any questions from the audience? So,
Did you actually ask who had anybody been to boarding school? Because people who go to boarding school or have been to boarding school for most of their life have a similar effect because they have a different effect. Okay, then. But that would have been quite interesting to see whether it is prevalent to those who have a bog standard comprehensive education like myself, or for those who actually went to boarding school.
So I am interested about adolescent sleep in boarding school, and I've just started a study looking at that as well, because I think boarding school is really unusual. It's kind of one of the few places where young adolescents are sleeping in the same space as each other. I didn't ask that information, but one girl offered it and said she went to boarding school. And I think the interesting distinction is that boarding school sleep is very regimented. So, for example, a lot of them don't allow you to have your phone at night. You have to have, you can't make noise, you have to have the lights turned off. And the difference she was making was she said that the phones were taken off them, and so she found that it was useful to have that distraction removed, but that it wasn't removed anymore. But I think, boarding school is a really interesting arena I'd like to look at.
excellent. Got two questions we might do just briefly. First, the person at the back and then down here.
Yeah, hi, Andy Milton from the Grounded Research Team at Ardash. You just alluded to actually with your comment about mobile phones.
Yeah.
I just wondered how much it came up in your research about the sort of ability or the need to be constantly on all the time. I've been teaching recently in secondary schools, and I asked one of my forms what they did with their mobile phones at night. More than half of the students in my form slept with them under their pillows on charge because they didn't want to miss out on it buzzing.
It's really interesting that exact point came out of a qualitative study looking at adolescents using their phones at night, and one of them was that they'd sleep under their pillow on loud or on vibrate, so that if they got a notification in the night it would wake them up because they didn't want to miss out on what was happening at night, which is obviously really bad. There's definitely a link between phone use and poorer quality sleep. I think it's slightly muddied by the fact that if you can't sleep at all ages, if you can't sleep, you'll tend to go on your phone. So often you'll see that higher phone use in adolescents with poor sleep because they can't sleep, so they're playing on their phone at night. But yeah, in terms of this study, the main things they seemed to say was that they knew it was a problem and they sort of tried not to, but they weren't necessarily very disciplined at not going on their phone.
Excellent, thank you. One question down here, Sheila, sorry.
Hi, did you speak to any first years who were either not adolescents or did not live in halls?
No, because I was specifically interested in adolescents sleeping in close environment to other people. So I specifically wanted typical age undergraduates who were living in halls. But it's an interesting question. I mean, obviously people of all ages and all situations can have sleep problems, but this study was specifically about what is it about, sleeping in close proximity with your peers in halls that affects sleep, which I guess you'd lose if you were in other settings.
Thank you very much, Lucy. That's really fantastic. And thank you, if you can join me in thanking all of our three early career researchers. I think we've had three fantastic presentations this afternoon and really diverse, even if they are linked. But really, really excellent stuff. And we haven't done them justice by only giving them 10 minutes. So thank you very much. I hope all the undergraduate students in the room will take those findings back to their peers and start sharing them and thinking about how they might change their behaviours accordingly. I know I wouldn't have. So okay, so I'd really like to invite, we've got 15 minutes before the end of the day, and it's been an excellent afternoon. I'd like to invite our four speakers up to the front here. We're going to have a little bit of a discussion. I'm going to do a quick fire round to ask them what their key priority question for youth mental health is, having heard what we've heard today, and perhaps listen to some of the discussions over tea and talk, kindly facilitated by the MHF. So we have had quite a lot of these returned. If anybody else has any of those from their tea and talk session or would like to add in some more, please do give them to us, because I think we'll be writing this meeting up and putting it probably on the Health and Wellbeing website page, and we'll be trying to collate some of the themes that come out of that. So we really will be taking these ideas back and thinking about how we can work with them and use them. But for now, I'd like to ask Jade, Josephine, Barry and Simon to come up and just give us one idea, their absolutely critical idea, and then I'm going to open it up to the audience and see if those actually comply with the sorts of things that you're thinking about. So Barry, can we start with you? You've had more time to think about this than most.
So an idea for research, or an idea?
Yes. What's the top priority research question you think right now in youth mental health?
That's such a tricky question. I mean, my answer was going to be, I think there needs to be more funding in child mental health research, or more funding in mental health research generally. That was going to be my answer. But that's a cop-out, isn't it?
Yeah. Well, we need to give them the reason to give us the funding, Barry.
Yeah, I mean, well, I suppose my area of interest is finding interventions that are friendly and acceptable to young people, that are deliverable in spaces that are where they are by either themselves or the people around them, not in specialist psychiatric settings. So I suppose I would like to see more of that funded.
That's a work programme. Okay, thank you very much. Jade, can I come to you next?
Sorry, I didn't have an answer on the top of my head, but I'm quite interested in student mental health. And I think, so we've talked about sort of making interventions friendly for young people, and I think students are quite a unique sort of group. And I think that the issues that they face are quite different. And I know that there's sort of statistics show that suicide there's been an increase in suicide with students, so it would be really interesting to try to look at the interventions that are taking place in student mental health, but to try and actually more rigorously evaluate them so that they can actually be replicated. And there's the crisis, the mental health crisis among students is addressed appropriately.
That's brilliant. Thank you very much, Jade. I'm going to come to my esteemed colleague, Dean Macmillan, in a minute to talk a little bit about that, perhaps. But next one, Simon. I don't want to lose momentum.
Okay, thank you. It's a super question. I mean, I work and research in adults and older adults' mental health, and one of the things that strikes me is that the child's the father of the man, so the antecedents of adult mental health are often found in childhood and adolescence. So for me, prevention is a priority, and I think that picks up on Josephine's slide where she showed that only sort of 3 to 5% of overall mental health funding goes to the prevention of disorders. So I'd like to see a priority, a sort of shift from treatment to prevention, and if we want to be serious about doing that, we need to do that in childhood and in adolescence. So I'm always drawn to the words of Benjamin Franklin, which are that an ounce of prevention is worth a pound of cure. So that would be my priority.
Excellent. Thank you very much, Simon. I think we're all in that space at the moment. There's so little funding for adult and child mental health services that we need to be thinking a bit more sort of further backstream and thinking about getting on top of these things before they develop. And I stick with that statistic of 75% of adult mental health problems are formed before the age of 18. So we really do have to get on top of these things. Josephine.
Yeah, great, thank you very much. I very much chime with what's been said here already, especially around student mental health. The thing that I'm interested in is certain groups are at higher risk, and I'm interested in interventions that can help, that are kind of personalized and tailored and targeted to groups who are at highest risk, because we know that interventions, standard interventions, don't reach all groups and communities, and so anything we can do to kind of adapt what's out there, evaluate that better and replicate that as well. And I'm also very, sorry, just going to continue to talk, I'm also very passionate about just better data to make decisions. So better information that we can build on. So we have the APMS. We're now getting children and young people statistics, which were from 2004, now being updated to 2018 and launched this November. But I think we need to do that much more regularly.
That's brilliant, thank you. I'm going to keep the panel up here. Just to pick up on the student mental health theme, I'd like to just come to Dean and put you on the spot if I can, Dean, because Dean's been thinking about some of the questions that you mentioned, Dave.
Dean down here.
Yeah, Dean,
He's been having a
come
free
on
ride
down.
all day.
I said I'd be Brucey for the afternoon. This is my opportunity. I won't ask you to dance, okay?
One of the things I've been told by my wife is never to dance in public. I won't be dancing. We got together on the assumption I would never dance in public again, so it's not going to happen, don't worry. To pick up on a point that's just been made, we need better data, and there's clearly something going on around student mental health, but it's hard to track down decent data, so I think our approach would be to take the world-class science approach that we've adopted generally at York in terms of doing mental health work and starting to apply that to student mental health. And that does mean gathering some basic data on what the level of the problem is, what the potential causes are, and how you might intervene. World-class science takes a while. Because there does look like there's a problem out there around student mental health, there could be a temptation to run in, throw solutions at the problem without quite working out what the problem is. So I think our plans will be to take a bit of a step back, establish a cohort, a psychological wellbeing cohort at the university, run it at other universities as well, and there's certainly interest in that. So we can start to describe the basic epidemiology of what's going on, and then use that as a basis to start to intervene. I'd really caution against just running in and trying to solve the problem before you know what it is. There's a whole history of that in mental health. Enthusiasm for an intervention often runs ahead of the evidence, and I think we should make sure we don't make the same mistake with student mental health. I think we need to take a bit of a step back and take a slightly more rigorous approach to finding out what's going on.
And I think Lucy's presentation earlier on demonstrates actually admirably that these things are multifactorial probably, and there may be a range of interventions that we need to think about. You know, some of them could be structural. I mean, we were laughing about the working in bedrooms and, you know, the sort of sleep hygiene issues around that we never really think about when we construct university environments. But equally, that wanting to sort of socialise and not wanting to be left out. And, I mean, I was definitely one of those people. So I would have put off all of the bad news for tomorrow. So I'm keen to hear firstly from the students in the audience. Is there anybody who's prepared to speak up and give us some thoughts on what they think the key questions are?
Hello, hi. I'm a third year psychology student and a service user of quite a few years, and I've got two brief points. One was, I think, talking about comorbidity and general issues altogether. Especially when I was younger, in the service, I felt very ignored when I was saying that I had more than one issues. My therapist was very much like, no, we go this issue, then this issue, which I understand now makes kind of it a lot simpler, but I felt not listened to. So I think for younger service users, that's an important thing to feel heard on. And the other thing is, while I understand the talk of economics in research settings, I think especially with younger people, it's important to stress that they're not a burden, and that while it is important to have cost-efficient solutions, that was something that stopped me from accessing services for quite a few years, in my teenage years especially. So talking about prevention for the sake of economics is all well and good in service providers, but it can be quite disheartening for the service users. So
that's very a good point, helpfully made, thank you. And I don't think anybody's tried to imply that at all. I think quite the reverse. We've been trying to think about how we could speak the language of the people who commission care to try and really get them to sit up and listen to the value of the investment. As Simon said, you know, and what was your an ounce of prevention is worth a pound of cure. You know, we really want them to understand that this is actually about investing in future generations. And so I don't think anybody's at all meant to imply that this is there's an economic argument around this per se. It's actually much more about what we're trying to achieve long term.
Just a thought about your looking at your study. More, as you said, more and more young people, children and adolescents are being diagnosed before they get to university. So there are